Well, thank you everyone again for joining. My name is Harold Shugla. I'm an outreach coordinator at Cancer Support Community Central New Jersey. On behalf of Cancer Support Community Central New Jersey and Robert Wood Johnson University Hospital Somerset, we're happy to welcome you to the second session of Cancer Awareness and Health Disparities in the LGBTQ plus community, sponsored by the Far Hills Race Meeting Association, as well as Robert Wood Johnson University Hospital Somerset Community Health Partnership. During today's screening for breast cancer and the LGBTQ plus community session, we will be discussing breast cancer screening guidelines, breast density, and supplemental screening. Our presenters today are Dr. Ann Moch, Medical Director of Sanofi U.S. Breast Cancer Program at Robert Wood Johnson University Hospital, Somerset Steeplechase Cancer Center, and Alicia Rogers, an advanced practice nurse and BAPS Siperstein Proud Center. So thank you again, and Dr. Moch, feel free to take over.
Okay, thank you very much. I'm just making sure one more time that everyone can hear me.
Yes, and you know what, before you start, I actually just let 2 more people in, and I'll actually start the pre-presentation poll. Dr. Moch, sorry, I apologize for that.
Yeah, no, not a problem.
So I'm gonna launch the pre-presentation poll just so that we can test your knowledge. So if everyone that can hopefully see it, if you can answer the 5 questions that are up there, please. Okay, another 10 seconds. Oh, you know what? Guys, I apologize. So I actually selected the wrong one because we have several polls. Sorry, here we go again. So another minute. This is the correct one for today. Okay, so most people have answered, and I will share the results in about 5 seconds, just so that we can see who has answered what, just to get an idea, and we'll reveal the answers after the presentation. Answers are still coming in, so I'm just hanging on. Okay, sharing the results. So for the first question, we have 60% of the people that said true, 40 said false, 80% for the second one that said true, and 20 false, and 70%. 80-20 for the fourth one, and then 70-30 for the fifth one. So we'll do the post-presentation results again, share the results just to see how many of you have answered right. And Dr. Moch, you have the floor.
Okay, thank you.
You're welcome.
I'm going to spend the next few minutes talking about screening for breast cancer. We'll talk about mammography specifically initially, and then we'll go on to review density of breasts, why density matters. That's a very hot topic right now. And finally, we'll review some supplemental imaging studies that we have available in addition to mammography to screen for breast cancer. So just to review some basic principles of screening, for a screening study to be effective, the results of the screening study, early detection, needs to alter the natural course of the disease. So what that means is that based on early detection, treatment needs to be less harmful. For screening for breast cancer, healthy women cannot be harmed. And lastly, the test needs to be widely available. It needs to be relatively inexpensive and certainly well tolerated by patients. One thing that I very much stress in this talk and sort of stress in general is that mammography is the only imaging study that has been proven to decrease death from breast cancer. We do have other imaging studies available, as many of you are aware. We have ultrasound of the breast, we have MRI of the breast. Those are the most common in addition to mammography. Again, these studies are used in conjunction with mammography, but certainly not in place of. So widespread screening mammography has been around for about 30 years, 40 years. It started in the 1980s. And so for the past 30 years, 35% less women die from breast cancer because of screening mammography. So this brings us to the screening guidelines. There's a lot of confusion out there. A lot of confusion, perhaps misinformation, certainly among patients and even in the medical community. The confusion essentially started in 2009 with a recommendation from a government task force. Prior to 2009, the generally accepted protocol for screening for breast cancer was mammography beginning at the age of 40 and mammography every year. So in 2009, the government task force came out with a set of recommendations that suggested that mammography should start at the age of 50, not at the age of 40. And they suggested an upper age limit to stop mammograms, which is age 74. So mammograms for women for ages 50 to 74 and every other year rather than every year. And again, there was mass confusion and certainly in the medical community. This is a fairly busy slide just to sort of illustrate the various medical societies because of the government task force recommendations really came up with their own recommendations. The medical societies did not come together as one and issue one general screening guideline. Each of the societies has their own guidelines. Some of them are very similar. The American College of Radiology Society of Breast Imaging continues to recommend mammography beginning at the age of 40. No upper age limit. Upper age limit depends on life expectancy of that individual patient. And the recommendation is mammography every year. So you can see NCCN, the GYN Society, the Surgeon Society essentially follow those recommendations. The Family Practice Society does actually follow the recommendations of that government task force. So here at Somerset Hospital, Steeplechase Cancer Center, these are our recommendations for screening for breast cancer. We recommend mammography beginning at the age of 40 and every year thereafter. We do not recommend an upper age limit. Again, the upper age limit is based on the individual patient, based on life expectancy, and if patients have other medical issues. So just an example of a screening mammogram. The screening mammogram I'm going to show you comes from a woman who is 62 years old, no family history of breast cancer, and she was having no problems, just came in for a routine study. So as many of you know, a routine mammogram consists of 2 pictures of each breast. We do a side picture of the breast and we do a top to bottom picture of the breast. So 2 pictures for each breast. There are 2 breasts, so 4 pictures in total. So the first 2 pictures that I show you here are the side views of the breast. This is the right breast, this is the left breast. For orientation purposes, the nipple is here, the chest wall is back here. These next 2 pictures are the top to bottom view of the right breast, left breast. A little bit conceptually, perhaps a little bit more difficult to realize what you're looking at. The nipple is here and chest wall is back here. So on a mammogram, fat is black and tissue is white. So if we look at this side view of the right breast, we can see this breast is mostly black. This is all fat. This breast is mostly fat. The white that we see back here is actually the chest wall muscle that the tech has included on this view. So this is normal chest wall muscle and normal fatty breast. We as mammographers, when looking at a mammogram, one of the important things that we do is look for symmetry between the two breasts. The breasts are not completely 100% symmetric, but there is some degree of symmetry. In the left breast on this side view, we see this fairly large oval-shaped white mass here. On the top to bottom view, we see this lesion here. So very dense, very white mass. If you see the margins of this lesion, they look kind of jagged, sort of like a sawtooth type pattern. Whenever we see a mass on a mammogram, we always take the patient to ultrasound. We try to characterize the lesion on ultrasound. Does it contain fluid? Does it contain solid tissue? Does it contain both? If a lesion contains fluid, is it a cyst, for example? So this is the corresponding lesion on the ultrasound. We again see the somewhat oval-shaped mass. This is a very black lesion. This consists of solid tissue. There is no fluid in this lesion. And very nice correlation with the mammogram. We see these kind of jagged sawtooth edges to this lesion. And this turned out to be an invasive cancer. Again, 62-year-old patient, no symptoms, just came in for routine screening, and we found this invasive cancer. So this brings me to screening of the transgender population, which is perhaps a little bit more complicated. There is very, very little information in the literature, very, very few studies that have evaluated the risk of breast cancer, development of breast cancer in the transgender population. In fact, the risk of breast cancer is unknown. And there is no expert consensus on how screening should be performed in terms of age to start, the frequency of a mammogram, and for the transgender female population, the number of years of hormone use. There are a couple of studies that were performed several years ago, very small scale studies that looked at breast cancer within the transgender population. One thing to keep in mind is that neither of these studies looked specifically at screening for breast cancer. The studies were aimed at screening in general and overall general health. One study performed in the Netherlands looked at a little over 2,000 transgender women. What they found was that the incidence of breast cancer in transgender women was comparable to non-transgender men. Another study a couple of years prior to that in the US by the Veterans Administration looked at 5,100 transgender veterans, and they found no increased risk of breast cancer in that population. That study was markedly limited. They did not record hormone status of any of the patients. There were breast cancers that were undetected. Patients were lost to follow-up, and some patients died before they could be adequately evaluated. So risk factors in the transgender population are a little bit different than risk factors in the non-transgender population. Transgender women in general are at decreased risk for breast cancer compared to non-transgender women. That the reason for that is decreased exposure to estrogen and cyclic estrogen. However, transgender women tend to have a higher prevalence of dense breasts, which therefore increases their risk for breast cancer. In terms of transgender men, even transgender men who've had mastectomies, oftentimes there is a little bit of breast tissue that's left behind. The surgeons, for cosmetic reasons, may not do a complete 100% mastectomy where they remove the entire tissue. They leave a little bit of tissue behind, again, for cosmetic reasons. So the guidelines here at Steeplechase Cancer Center for the transgender population, for transgender women, our recommendation is yearly mammography. And these patients should start at the age of 40 and have at least 5 years of feminizing hormones. For transgender men with residual breast tissue, we recommend yearly mammography beginning at age 40. So just an example of a transgender patient who came to us for breast imaging. She is 66 years old. She has been taking feminizing hormones for more than 5 years, and she reports several incidents where she had direct saline injections into her breasts. And so what that means is that a syringe with a needle on the end is filled with saline, and several of these syringes are injected directly into the breast in various locations. The purpose of doing that is for cosmetic purposes to increase the size of the breasts. For direct saline injections, the effect is really only lasts for about a couple hours, certainly not more than 24 hours, and more likely maybe 2 to 4 hours. So this is her mammogram. We have the 2 side views of the breast. First 2 pictures, second 2 pictures are the top to bottom views. And you can see there's a lot of white tissue here, a lot of white tissue here. She has a relatively dense breast. She has a lot of glandular tissue. And what we noticed in her left breast, nipple is located here. We saw what looked like a mass here. On the top to bottom view, again, we saw what looks like a mass. So we took her to ultrasound, as we always do when we see a mass on a mammogram. And what we see is this round or oval shaped lesion, central black inside. This lesion actually contained fluid. Most of this is fluid. And this is actually what we call fat necrosis, which is essentially a reaction of the breast to the direct saline injections. You can sort of think of it as scar tissue in the breast. Again, called fat necrosis. It is completely benign. It is not cancer. It does not turn into cancer. However, on a mammogram, as I showed you, it can look quite ominous on a mammogram. So again, mammography, the only imaging study that we have that has been proven to decrease death from breast cancer. However, certainly as we all know, mammography is not, does have its limitations. The sensitivity of mammography can be as high as 95%, and that is in a fatty breast. In the literature, the sensitivity of mammography has been shown to be potentially as low as 30%, and that is in a dense breast. The reason for that is the dense breast tissue can obscure a lesion growing in the breast, and we might not see it on a mammogram. So that brings us to our next topic of breast density. Again, kind of a very hot topic in the literature. Oh, sorry. So the breasts are composed of glandular tissue and fatty tissue. And when we say that a breast is dense, what we mean is that there is a lot of glandular tissue as opposed to fatty tissue, more glandular tissue, in fact, than fatty tissue in a dense breast. And dense breasts, fatty breasts, everything in between is all within the range of normal. There's nothing abnormal about having a dense breast. There's nothing abnormal about having a fatty breast. In general, younger women tend to have a lot of glandular tissue. Their breasts tend to be very dense. And as women get older, that glandular tissue gets replaced by fatty tissue. So the density of the breast as women get older decreases. And older women tend to have fattier breasts. Breast density is assigned at the time of a mammogram. So density is based on a mammogram, not an ultrasound, not an MRI, based on a mammogram. So there are 4 categories of breast density. The first 2 categories are the fatty categories. The second 2 categories are the dense categories. And you can see from my color pie chart here, 80% of patients straddle that line between fatty breasts and dense breasts. So I also wanted to show you examples of each of the 4 different categories. These are 4 side views of the left breast. Again, for orientation purposes, the nipple is here. The chest wall is back here. Fat is black on a mammogram. Tissue is white. So again, this tissue back here, this is the musculature of the chest wall. These white dots are lymph nodes under the arm. These are completely normal. This is where they normally live. So you can see in this first picture, the breast is mostly black. So this breast is almost entirely fat. There are some white lines that we can see here. These are vessels and connective tissue supporting structures. The second picture that we have here, we're starting to see some more of that white tissue. There's more glandular tissue here than in the first patient. However, the breast is still mostly black, mostly fat. And then as we get to the third and fourth categories, we start seeing significantly more of this white glandular tissue, particularly here on the third picture, and certainly in the fourth picture. There is this very large area of almost completely white, extremely dense tissue. So breast density is really important for two reasons. Breast density is an independent risk factor for breast cancer. So if you have a dense breast, you are at increased risk for breast cancer just because your breast is dense. So that's the first issue. The second issue is, as I mentioned, the masking effect. And again, what that means is that in a dense breast, a small lesion, a small cancer could be growing, and we may not see it on a mammogram because it's being obscured by that dense tissue. And just to illustrate the masking effect, I think this is a very nice illustration. This is my polar bear analogy. So here we have a polar bear laying on a bed of snow, sleeping. When it starts to snow, when the blizzard rolls in, this is what we're left with, thus the masking effect. So many of you may have noticed in the letters that you receive from your breast imaging studies that there is a sentence or two regarding breast density, a sentence that may say, you know, that your breast is that you do have a dense breast. There are breast density laws in almost every state. The laws are state by state. It's not a federal law, although at some point it probably will be. All breast imaging facilities, all mammography facilities must notify their patients if they have a dense breast. The reason for that is that patients with dense breasts may benefit from additional studies in addition to mammography. So that brings us to the topic of supplemental screening. That is, what are these additional imaging studies that we have in conjunction with mammography? Again, we use these studies in conjunction with, not in place of. One thing to keep in mind is that there are no studies in the literature that show decreased death due to supplemental screening. Supplemental screenings do absolutely detect an increased number of cancers when used in conjunction with mammography. That earlier detection of breast cancer certainly relates to improved treatment, less harmful treatment, for example. However, there are no studies that have shown that the death rate is affected. There is also no expert consensus on which of these supplemental screening studies, if any, a patient should have. One thing to keep in mind is that for these supplemental screening studies, we're talking about patients with dense breasts at average risk for breast cancer. Patients who are at increased risk for breast cancer, that's a completely different story, a completely different topic. These are for patients with average risk and dense breasts. So we have tomosynthesis, which is 3D mammography. I've included 3D mammography in the supplemental screening portion. Perhaps I should include it with the 2D category. 3D mammography is now, rather than a supplemental screening study, becoming more of a gold standard, more of a standard of care. But for our purposes here, we'll talk about it as a supplemental screening study. We also have ultrasound available, MRI available also, both are widely used. Molecular breast imaging, MBI, and contrast enhanced mammography. I'm not going to talk about these two modalities other than to say that they do in fact exist. So 3D mammography, similar to 2D mammography, is low dose radiation to the breast. As many of you know who've had a mammogram, for a 2D mammogram, your breast is placed in compression and the X-ray tube is aimed at your breast and one picture is taken. So for a 3D mammogram, very similar, the breast is in compression, but rather than the X-ray tube stay stationary, for a 3D mammogram, the X-ray tube actually moves along an arc across the breast, and several pictures are taken along that arc. And then the pictures are reconstructed by a computer into essentially a 3D rendering of the breast. So we as mammographers are able to look at a 3D mammogram. We look at the tissue planes slice by slice. The slices on a 3D mammogram are very, very small, 1 millimeter slices. And the advantage for that, for us as mammographers, is that we are looking at one slice at a time. So the tissue above the slice that we're looking at and the tissue below the slice that we're looking at are essentially removed. So that dense tissue is removed. And particularly in a dense breast, we can potentially find a small lesion that we may not be able to see on a 2D mammogram. So in the literature, 3D mammography finds an additional 2 to 3 cancers per 1,000 patients screened. And just an example of a 3D mammogram, we have a side view of the right breast. The first picture here is a 2D mammogram. And we have a lot of white tissue here. This breast is extremely dense. This is a biopsy marker. A patient had a previous benign biopsy in the past. This is what a very small biopsy marker looks like. So we see nothing other than dense tissue on this 2D mammogram. This is one slice from the 3D mammogram. That biopsy marker is located here. And what we're starting to see is what looks like a mass located here. The nipple is here. This is right behind the nipple. Again, patient, 48 years old. This was a screening study. So this is the top to bottom view of the right breast. We have the nipple here. Here's our biopsy marker. And all we see is this very dense white tissue. One slice from the 3D view is the second picture here, and we can see this lesion located here. Again, whenever we see a mass on a mammogram, we always take the patient to ultrasound to better characterize the lesion. And this is the lesion that we saw on the ultrasound. This is a black, solid, very irregularly marginated mass, jagged margins here, angulated margins. And particularly behind this lesion here, angulated margins. We biopsied this lesion, and this was an invasive cancer. We also have ultrasound available, whole breast screening ultrasound. There is no ionizing radiation involved in ultrasound. What happens with an ultrasound is we pass sound waves through the tissue, through the breast, and we're able to acquire images based on the interaction of the various tissues with the sound waves. Again, no ionizing radiation. Ultrasound finds an additional 3 to 4 cancers per 1,000 patients screened. And just an example, 77-year-old patient screening mammogram. This is a side view of the right breast. We have very dense white tissue. Nothing is seen on the mammogram. The mammogram is normal. So the patient was brought for a screening ultrasound, and what we see on the ultrasound is this solid, very small black lesion, and this was biopsied. This was an invasive cancer. Just another example of the benefits of ultrasound. This is not a screening study. This patient is 55 years old, and she came to our breast center because she had a lump in her right breast, sister with breast cancer after menopause. And we have the side view of the right breast, and we have the top to bottom view. There's a lot of white tissue in this breast. This breast is very dense. If you can see this white dot here and white dot here, this is the lump that the patient felt. And we saw nothing other than dense tissue on this mammogram. We did take the patient to ultrasound. We put the probe on the lump that she was feeling, and this is what we saw. Again, solid, irregular, jagged mass. There's a soft tissue extension of this lesion superiorly, and we biopsied this lesion. This was an invasive cancer. Also available in addition to mammography is MRI. MRI, like ultrasound, does not involve radiation. We expose the breast to a magnetic field, and again, we acquire images based on the interaction of the breast tissue with that magnetic field. MRI is a little bit more sensitive in that it detects up to 10 to 15 cancers for 1,000 patients screened. And another example, a 56-year-old patient who 5 years prior to this mammogram had cancer in the other breast. So she had left breast cancer. These are two pictures of the right breast. Left breast cancer, had a mastectomy 5 years ago, and she now comes to us because she has several lumps in her breast. This is the side view of the right breast. This is the top to bottom view. Again, a lot of white tissue, very dense breast. And if you can see these triangular markers here, several of them, these mark areas where the patient felt lumps. Oftentimes, whenever a patient has a lump, we put a marker on it. So on the mammogram, we can see where the palpable abnormality is. So all we saw on this mammogram, despite the fact that we have these markers, is just dense tissue. So we offered the patient an MRI. And these are two pictures. The top picture is the equivalent of the top to bottom view of the right breast. We have the right breast here. As I said, the patient had a left mastectomy. There is no left breast here. This is the chest wall. This white structure here is the heart. This is the second picture here is the equivalent of the side view of the breast. We have the nipple here. The chest wall is back here. Heart is located here. And so what we have is this white mass located here on the top to bottom view. This lesion is here. We biopsied this mass, and this turned out to be an invasive cancer, not seen on the mammogram. So just in summary, of the supplemental studies that we have available, tomosynthesis, which is 3D mammography, finds an additional 2 to 3 cancers. Ultrasound, an additional 3 to 4 cancers. MRI, a little bit more sensitive, finding an additional up to 15 cancers. Again, very important, these studies, ultrasound, MRI, are used in conjunction with mammography. Nothing replaces a mammogram in screening for breast cancer. And that's it.
Great. Alicia, did you have anything to add before I do the post-presentation poll? I don't know, Alicia, you can hear me. You might be on mute.
Okay, I'm here. Can you hear me?
Yep, I could hear you now.
So I just wanted to address even Dr. Moch's comment about why we don't have numbers for the LGBT community and why there's such huge disparity in care when it comes to the LGBT community. And a lot of stigma and biases has kept this community from care. And it can be simply your front desk person not addressing the person at the proper pronouns and misgendering them. And this keeps this population from getting the appropriate care they need. So it keeps us from having the appropriate numbers to know when do we start screening them? How do we address their needs? So I just wanted to add that, you know, it's very important to have culturally sensitive and gender affirming healthcare. And that's what will keep this population in care.
Okay, great. Should I launch the post-presentation poll again?
Yes.
Sorry, I was on mute myself. So I'll launch the post-presentation poll, and then we can go over the questions that are in there. Here we go. And if anybody has questions, feel free to just post them in the chat and we'll address them at the end. still have some people answering, so I'm just going to leave it up for another 10, 20 seconds.
Evan, I can discuss a little bit about, we both can talk about a little bit about the use of hormones. Do you have a question in particular?
So this is, this is in regard to the question that's in the chat. Could Dr. Moch talk more about the role of hormones? She can. Let me just, let's just finish going through these questions and then we can address that. Okay, I'm going to end the poll and I'm going to share the questions. And then Alicia, if you want to take over going through either your questions or Dr. Moch can answer the first two questions, because I know those were the two questions that she presented.
Okay, so the recommendation for screening mammography is again, beginning at age 40. Mammography should occur every year. Beginning at the age of 40, again, there is no upper age limit. The time to stop having screening mammograms really is on an individual basis, depending on life expectancy. The general thought is that if life expectancy is greater than 5 years, then mammography should continue. For example, an 80 or 85-year-old patient, that certainly exceeds the upper age limit for the government task force recommendation, which was 74. But take an 83-year-old patient, for example, in very good health and not really a lot of other medical issues, should really consider continuing on with mammography. Another 80, 83, 84-year-old patient may have a host of other medical issues. The life expectancy may not be that long, and so therefore screening mammography may not be warranted in that patient. The second question is if I have dense breasts, that means that I have a lot of glandular tissue as opposed to fatty tissue. That is true. A lot of confusion, when we talk to patients about whether they have dense breasts or they don't have dense breasts. Density means you have a lot of glandular tissue, definitely.
So question number 3 is, do gay men have an increased risk of anal cancer? And the answer is true. Due to exposure to HPV and not getting anal pads, gay men do have an increased risk of anal cancer and not being diagnosed with anal cancer as well. Are transgender women more likely, 2 times more likely to have HIV? And the answer to this is true as well, because of increased disenfranchised in the workforce. A lot of transgender women are exposed to sex work for money. So, and not housing for, sex for housing, sex for food. So it does put them at increased risk of HIV. And the last question is, theoretically, is the lesbian population at increased risk for ovarian cancer? And the answer is true. And this is because of being disenfranchised and not feeling welcomed in healthcare facilities. The lack of testing keeps the lesbian population out of care as well.
Okay, and so I have one more poll, which is just the evaluation. If we could just do that before we go into the questions. So I'm going to go ahead and launch that if we can quickly do that, and then we'll get right into the questions. Thank you so much. I'll leave it on for about 10 more seconds. Thank you for completing the evaluation. And so, Dr. Moch, the question was directed to you, and it was to talk more about the role of hormones.
So there is definitely a hormonal influence on the breast tissue. Risk factors for breast cancer often include exposure to hormones, as I mentioned. That we look at the age that a patient first got her period. So the younger the age of menarche, the older the patient is when she goes through menopause. That translates into a longer period of time for the breast to be exposed to cyclic estrogen and progesterone as well. So that does definitely increase risk for breast cancer. It is definitely a risk factor. In terms of hormone use and exogenous hormone use, as I said, as I mentioned, one of in the transgender population, in terms of screening, we do look at the number of years that patients have been taking feminizing hormones. That does put them at an increased risk for breast cancer as well. That population has less lifetime exposure to estrogen and certainly progesterone. So for that reason, the risk factors, the risk of hormonal influence on the breast tissue for breast cancer is less. There are some cancers that are fueled by estrogen and progesterone, so something to keep in mind also. Not all cancers, not all breast cancers, even invasive ductal cancers, not all of them are the same. Different types of cancers have different types of tumor markers, have different types of receptors, and again, some of them are fueled by hormones and some of them are not.
Okay, we don't have any additional questions in the chat box. So that basically concludes today's session. Please be sure to join us next week, which is our last session on oncology care for the LGBTQ plus community, same time at noon. Thank you all once again. Once these recordings are approved and available, I will share the link to all that registered. Thank you so much.
Thank you.
Thanks, Alicia. Thank you, Dr. Moch. I appreciate you taking the time out of your busy schedules.
Thank you.
Bye-bye.